Good afternoon and welcome everyone. Dr. Debbie Gold joins the Osher Lifelong Learning Institute at UC Berkeley for the 7th time during the COVID pandemic. I am Susan Hoffman, the director of OLLI at Berkeley. Dr. Gold is an epidemiologist who has not only engaged OLLI and Berkeley in these previous sessions, she has also presented more than 4 presentations to the MAVEN project, which advises medical workers across the country with the latest research, science, and healthy practice on the COVID pandemic. With today's invite, you were given the opportunity to ask questions. Dozens of questions came in, and unfortunately, we won't be able to get to all of them, but we'll do our best to get to most of them. Thank you for sending them in. Understand that I have organized these questions into the following areas: the Delta variant and breakthroughs, vaccines, side effects, and boosters, long haulers, and then risk assessment, which is making decisions based on science and best practice during the pandemic. And then finally, the CDC, the Center for Disease Control. I hope you can all stay with us for the hour. If you need to leave, know that we will be posting this presentation a few days after today. We will caption it and put it up on the OLLI YouTube site, and we will provide it for Berkeley News Center to make a podcast. Let's begin, Debbie, with the Delta variant. It seems that it is an inflection point. We have the Delta variant is more contagious than we expected. The viral load seems larger and perhaps more significant, and the virus stays in the body longer. Can you tell us more about the Delta variant?
So the Delta variant was first identified in India in September of 2020 and has spread rapidly around the world and is present currently in at least 124 countries. It is highly transmissible, probably twice as transmissible as the original Wuhan strain. We don't have great data the way we did have with Alpha or the B117 UK variant to suggest that it confers an increased risk of severe disease and or death, which the Alpha variant does. And so I think there's some outstanding questions about that. I have read some references to Delta variant being more virulent compared to the original wild type and some of the other variant strains. But at this point, we just know that it is very highly transmissible. And so the implications are that it can spread extremely rapidly in pockets where there is a high degree of, there are a lot of unvaccinated people. And just the sheer numbers will dictate that that's going to lead to more hospitalizations and deaths. Again, mostly in unvaccinated people. There's also another important implication. We used to talk about herd immunity very early on being around 70%. This is the number or the percentage of people who need to be vaccinated or immune by natural infection, and preferably by vaccination, because that's a more durable way of becoming immune, in order to prevent spread in the community. So with the original Wuhan strain from December of 2019, the herd immunity was thought to be somewhere in the range of 70%. But as these more transmissible variants have come on the radar screen, it's pushing up the percentage of people who have to become vaccinated in order to prevent spread. So we may be in the range of about 85% now, and maybe higher. And just to give you a means of comparison, Measles is about the most transmissible infection that we have. And herd immunity for measles is 95%. So 95% of the population has to be vaccinated in order to prevent spread in a community. And so we're inching up towards that as the variants become more and more transmissible.
Debbie, do we know anything else more about its transmissibility? Is it any different than the COVID-19 or?
So it is twice as transmissible compared to the original Wuhan strain. It's about 50% more transmissible than the Alpha variant, which is the B.1.1.7 or UK strain. We know that the increased transmissibility that the variant had was probably because of a prolonged period of shedding virus, so that individuals who were infected could infect other people for longer periods of time. And I can't recall if there was also an increased amount of virus, increased viral load there. We don't really know what the mechanism of increased transmissibility is for Delta yet with certainty. So we just have to accept that there is some change in that virus that is conferring the ability for it to be transmitted more efficiently. And yeah, so I don't know what the mechanism is.
And I think we're hearing anecdotally, that people are in situations where they may be in simply a conversation, a simple back and forth conversation with someone where it might be transmitted. Does that seem to, can we qualify that at all around its infectiousness?
Well, we know that the virus is airborne, and certainly situations where there's no masking, no distancing, indoors with poor ventilation, those are all circumstances which would encourage the transmission of the virus. But there have also been outbreaks that have, in fact, there have been some large outbreaks, even in Marin County, outbreaks where it's really not clear what the conditions were. And there was recently, I think yesterday I saw, or the day before, I saw that there was a super spreader event at a big concert, outdoor concert in Michigan. So if you have a lot of people who are crowded together, and there's not a lot of vaccination going on there, then you can have transmission even in outdoor spaces. But in general, outdoors, good ventilation are not conducive to transmission.
And 6 feet, I guess.
Now there's 3 feet for schools and 6 feet for people who are not in school. And, I think the guidelines are changing.
Well, and with it having a larger viral load and staying in the body longer, is there anything to be said about that? Is there more long haulers within the people getting Delta variants?
Unknown.
Okay.
And I think, and the question that I have about long haul is, if you're fully vaccinated and then you get a breakthrough infection with Delta or with something else, could you still develop long COVID? And that's a scary thing. And that's something that's driving me to change my own behavior, not wanting to get even a mild super infection. Since we know that individuals who develop just mild COVID can still get long haul symptoms. And so I don't want to get even a mild breakthrough case. of Delta or any other variant, because I'm concerned about that, and I want to reduce my risks of getting that. When we talk about viral load, it's different from HIV viral load, on which we're measuring on a blood test. Viral load that we measure for individuals infected with SARS-CoV-2 is actually the viral load in their nose, because that swab goes either in the front of the nose or way back in the nose, like almost to your brain. And it's that, the amount of virus that's in that compartment of your body that's being measured. And so that's where, and we're not even really measuring viral load, we're measuring something called cycle threshold, which is it's an indirect measurement of viral load. That's a measurement that's produced by a PCR result.
Got it. Okay. Well, let's talk a little bit more then about the breakthroughs. And so what is the percentage of fully vaccinated people who are getting COVID? And how many of those people are getting the Delta?
So those are really excellent questions, and there are not good answers. The CDC has said that they will only collect data from states about breakthrough infections which result in hospitalization or death. So anybody who gets a breakthrough infection that gets identified and gets reported to a local Department of Public Health, it doesn't actually get to a repository at the CDC unless it's a severe case. And a lot of people who might develop a breakthrough infection might have very mild symptoms and not even seek testing. So we really don't know what the risk is of getting a breakthrough infection. The CDC has said, so they post, I think the last time they posted breakthrough infections on the website was July 19th. And as of July 19th, it was something like 5,900 cases that had been reported to have resulted in hospitalization or death. And then some of those were incidental findings. So somebody got admitted to the hospital for another reason, but had COVID testing and was identified as a hospitalized case that had COVID, but they really were in the hospital for another reason or actually died for another reason. And those are also in the mix. So we don't have really good data about this. The other thing is that not all states report to the CDC or even keep track of breakthrough infections. So nationally, we don't have a very good picture of what the risk is for developing a breakthrough infection. I saw yesterday, I think in the New York Times, that they had made an estimate that it was less than 1%. Or 0.1%. I can't remember. I didn't read the article because I thought there is no way that you can make that kind of an estimate with the kind of data that we have access to.
All right. Well, then how about for us who are vaccinated? How likely is that we could give COVID to another vaccinated person? Is there any understanding about that? I'm not hearing you very well. You're kind of breaking up, and I'm wondering if it's my problem because my husband is on a Zoom upstairs. So I'm going to just text him to go on to the Ethernet, or he can go on his hotspot, and that will free up a signal for me. So hold on for a second. I'm so sorry to have to do this. That's quite all right. I need to ask the person who's in my study right now to also leave with his technology, because that may be breaking up our conversation as well.
Okay, so this should help. Okay.
All right. Thanks, Debbie.
Repeat the question, please. Sorry, I didn't hear what you said.
No, so how likely is it for in a group of vaccinated people that a vaccinated person could be carrying COVID and could give it to another vaccinated person?
Okay. I think that can happen. And I think it can happen just from anecdotal information that I've been hearing. For example, my friend's niece went to a bachelorette party, and these are nurses, by the way, fully vaccinated nurses, went to a bachelorette party in somewhere, I don't know, the Caribbean, and of the 9 of them, 8 of them got infected. Symptomatic, mild. The case is either that one individual infected all of them, or one of them got infected somewhere along the way because they were coming from different places in the United States, and then one went ahead and infected the others. So I think that it's possible. We certainly know that it's possible with other variants that fully vaccinated individuals can infect other people. And there was just a report, I would say, yesterday or 2 days ago about an an individual who was fully vaccinated, who was infected with the alpha variant, who was able to successfully infect other people. So it is possible that that could happen. And that is something else that's been driving a change in my own behavior about having people over, which I was doing on a regular basis, no masks, no distancing in the dining room, having dinner, and I'm not doing that anymore. So
I think there are many questions in our chat room about how you are changing your behavior. And in light of what you know, we were going to get to that.
So we can save it for the end, but I think it is possible that people who are fully vaccinated can get infected, very mildly infected, or even asymptomatically infected, and infect others. And I think that that is theoretically possible. I've only seen, I have not seen documentation of that for Delta, but just these stories that I hear about multiple people being infected in a group suggest that it might be able to happen.
Mm-hmm. It seems like we've really been surprised at how the Delta variant has been proceeding, that we're hitting a surge earlier than was expected. That there is much more contagion among people vaccinated. Is there anything that people can do to know just what their protection level is around their antibodies in their body? Is there an antibody test for something like that?
There is, and I suggest that people who are at high risk of not having a robust response to vaccine, and that means organ transplant recipients, people who have hematologic cancers, people who are on immunosuppressive drugs. I think that it's not a bad idea to try to get an anti-spike protein antibody. That antibody, that test is available from Quest and from some other large labs. And you have to be very specific about the antibody test that you want, because most of the antibody tests are against the nucleocapsid protein, that does not help you at all. You want to know if you have responded to the vaccine, and the vaccines are spike protein based. And so you want to know how much antibody you have made to spike protein. And even better, if you can get a quantitative antibody level, that will tell you how much antibody you have. And that tells you how much antibody you had on the day you had the blood tested. And it's even, it makes more sense if you have detectable antibody to check it again in some period of time, like 3 months or 6 months, so you can understand if you have waning antibody and if that antibody level will wane below the level that would be protective.
Very good. Thank you for that. And QS, is that something that people do on their own, or is that something through their medical provider?
It's through your medical provider.
Okay.
And the provider might not know that they have to be careful about what tests they order, because the anti-nucleocapsid is only going to tell you if you've had an infection with SARS-CoV-2. It is not going to tell you anything about whether you have responded to the vaccine. So you want to know, did you make antibody? How much antibody did you make? And then over time, is that antibody level still staying in a reasonable and a lot of times I think you can't get that quantitative information, but you could get a yes, no on whether you have detectable antibody to the spike protein.
Since we're talking about testing, could we talk about the COVID-19 tests, the PCR that's been recommended? Should we be using that more liberally when we gather with people, people who are traveling, visiting, et cetera? What do you recommend on that?
So I just had nieces and nephews coming to San Francisco from all over the place. And I said, you know what, this was maybe within the last month. You don't need to test when you come here. We're good. You don't need to test before you see grandma and grandpa. My parents are in their 90s. You don't need to test. We're good. Now it's a different story. So if I would say, being a very conservative person and very risk averse, I guess would be a better way to describe it. I would say the kids who are flying in from New York and Vermont and, wherever, where we know that there's a lot of increasing, the cases are increasing. I would say that I would like them to test 3 days after they get off the plane and not see my parents or maybe even me until they get a negative COVID test 3 days after arrival.
So we're back to the same level of quarantine, testing, and then
it depends what your risk tolerance is. And I have a low risk tolerance. If somebody's not going to respond to a vaccine, that could be my father, who is, 95 and a half and has a lot of medical problems, although he's not immunosuppressed. But I'm thinking, you know what? There were no 95-year-olds in those phase 3 studies, and there were no 95-year-olds in the vaccine studies that were subsequently published in the elderly. So it really only went up to like 91. And so I don't know if my father has made a robust response to the vaccine or not. So we're just trying to protect him as much as possible.
And so we are back to the safe distancing and the mask wearing and, for our best practices.
But I'm not, so I should say that when I'm in the grocery store, I never stopped masking in the grocery store. I should just say that. But I do try to distance in a place like that where I don't know what the vaccine status is of those other people in the grocery store. I'm in San Francisco and, 69% of people are fully vaccinated here, but I still don't know about that other, 31%. And so I do try and distance and I continue to wear a mask. But I don't know, when I'm outside and I'm just going for a walk, I don't wear a mask but I do distance. And if someone's coming towards me, I just cross the street.
And you walk with a mask in your pocket.
I don't actually. I don't.
I do. All right. Well, let's move for the moment to the vaccine boosters. What's your thought about that? When do you think they'll be available? And we've got a couple of questions around if in fact you've taken Pfizer, can you get a Moderna booster or et cetera? So can you go into that area of boosters? I know we're not there yet. And do you have any sense at all when that might be available?
I think the question might be, are they going to be necessary for people who took mRNA vaccines? And If they are necessary, will it be for everybody or will it be just for some? So the ACIP, which is the vaccination advisory arm to the Centers for Disease Control, met last Thursday to discuss the need for boosters in people who are immunocompromised. And that would be, again, organ transplant recipients, people with hematologic malignancies, people with solid organ cancers actually do quite well with the vaccine. And in a recent study, they did great. People who are on immunosuppressive drugs and certain like chronic lymphocytic leukemia is a big one for people who tend not to respond very well to the vaccine. And so the discussion was whether those people should receive booster doses and when they should receive them. And so I have not actually seen a formal statement from that meeting yet. And so the advice will then go to the director of the CDC in order to sign off on it or not. So I haven't seen anything formal from that yet. As far as everybody else, I noticed that just in the lay press that people over 65 are being bunched together with people who are immunocompromised as candidates for vaccine and saying that this is coming. And I resent that. I resent, having being over 65 as being bunched in together with immunocompromised people, because I don't think of myself that way. And I would not have thought of my patients that way when I was still working. I mean, it's one thing if you have an organ transplant, but if you're 70, but if you don't have an organ transplant and you're not on immunosuppressive drugs, you're good. I think that that's not warranted. So I'm thinking, the way I think about this, I think individuals who are immunocompromised are going to be in line to get a third dose. And I think they're going to look for a way to do that without requiring FDA approval of the vaccines and to make it unnecessary to apply for an extension of the emergency use authorization in the absence of full FDA approval. For the rest of us, I think the data are really still outstanding about whether we need it and if we need it, when we need it. The Pfizer, well, I'll start with Pfizer and then I'll talk about AstraZeneca with Pfizer. So Pfizer is currently doing a study using their phase 1 participants, and there are 45 people in this study. 15 of them, and these are not immunologically, these are immunologically normal people. So 15 of them have now received a booster, a just regular old Pfizer third dose. And it was timed about, I think it was 6 months after the second dose. A third of them, so another 15, got a booster that was tweaked in order to imitate the Delta variant better, with the thought that it would then confer increased protection specifically against Delta. And then the third group of 15 got a mixture of the two. And I have not seen data from that booster study that Pfizer is running. I have seen data from the UK, which is looking at AstraZeneca, which is their chimpanzee, it's an attenuated chimpanzee-based adenovirus platform that they've are using for their vaccine. And they are using AstraZeneca. They're using people who are vaccinated. I think the study was that they were fully vaccinated and they're giving, oh no, this is an ongoing study too. They're giving one of 7 different boosters. They're either you get the same vaccine that you got for your first 2, or you get AstraZeneca instead, or Moderna, or Pfizer, or there are 2 others, vaccines that are not FDA approved here, or not approved at all. I think one of them is a Chinese vaccination, and then they have a placebo arm as well. And so that is an ongoing study it's a mixing study, and I have not seen data for that yet. It's a very large mixing study. And then I saw a mixing study where AstraZeneca and Pfizer were mixed, and where the first dose was AstraZeneca and the second dose, I believe, was Pfizer, or it could be the other way around. And those patients tolerated the vaccines well and had a robust response. But that's not booster, that's a mixing study. So I think that the jury is out about what's going to happen with boosters for the general population. And I think while we're waiting for data about this, we also have to think about the ethics of giving booster vaccinations to otherwise normal, healthy people, especially in communities where we live, where the vaccination rates are pretty high already, and that we would anticipate a lower amount of Delta circulation when much of the world is still unvaccinated, most of the world. So is that really an ethical way to use vaccines?
Mm-hmm. Yes, I've heard that moral argument, ethical argument. For so many of us do things that are immune boosting, because we've been told it gets weaker as you get older, more sedentary, et cetera. Is there a list of immunosuppressant, situations that would qualify for the booster? Theoretically, I mean, is there a list of things that if in fact someone went to their doctor and said, I'd like to be in line for the booster, would they, how do they argue for themselves?
Well, I think the provider should be able to identify somebody who is immunocompromised. So it's anybody who has a solid organ transplant, especially if they're taking mycophenolate, which confers a special risk for non-response to vaccine. Anybody who is taking prednisone, even as low as 5 to 6 milligrams a day. Those individuals in one study from Israel, I think, of people with rheumatologic diseases, they did not mount a robust response to vaccine. Anybody who is taking Rituxan or rituximab, which is an immunosuppressant that is widely used for lots of different things, those people are also in a special category of people who do not mount a robust response to vaccine. And then patients who have chronic lymphocytic leukemia, of the thinking about lymphomas and all the other sort of hematologic malignancies, those patients with CLL are in a special category. And they tend not to respond to vaccine in most cases. So I would say those are the sort of general categories, thinking about it in terms of the drugs that you would take rather than the specific diagnoses for lupus and rheumatoid arthritis and things like that.
Got it. Okay.
There are gazillions of diagnoses that tend to use, similar immunosuppressive drugs are used for those. Inflammatory bowel disease, chronic psoriasis, and there's some other sort of skin disorders where those drugs are used also.
I'm surprised to hear about the prednisone.
Yeah, I was a little surprised. I've seen it in only one study, and it wasn't very much prednisone, 5 to 6 milligrams a day. That's not much, but yet those people did, and again, this was a small study. I think it was, I don't know, 40 patients, single center. I haven't seen it repeated anywhere, or, you know, like anybody doing a similar study, but yeah, as little as 5 to 6 milligrams of prednisone did seem to impede the immune response. I was very surprised to see that. I would have predicted 20 or more, 20 milligrams
Sure.
a day or more. Yeah.
Sure. Well, what I'm going to do is I'm going to kind of run through some quick questions with you, because some of them have a kind of specific nature to them, but are also translatable out. Should people who've had COVID, should they get vaccinated as well?
Absolutely, they should.
Okay.
The durability of the immune response will likely be much better than natural infection. And it is absolutely indicated that people who have had COVID should still take the vaccine, because you want to have a robust response and you want to have a durable response. And so we know from the phase 3 studies and subsequent studies that people who are vaccinated oftentimes will make higher antibody titers than people who who had natural infection, and those are people who would be in like the control group. We also know that people who had prior COVID infection and then they take a vaccine, they get a super high, very robust response to vaccine.
Again, a specific question. Grandparent asks, if a teenage grandson had COVID and one vaccination, should they get the second one?
I say yes, until we have some data to suggest that you don't need the second vaccine. The grandson should get the second vaccine. Yeah, the second dose.
This question is perhaps answered by today's announcement about what's happening with all medical facilities. But the question was, doesn't Kaiser require all staff to be vaccinated, and why not?
That is such an interesting question, because I, was in the Kaiser system for my whole career. And we used to have to deal with influenza shots, I will say that they strongly encourage vaccination, but whether they will require it as the condition of employment, we'll have to wait and see. There are 60 medical organizations that have signed on to this request that healthcare organizations require COVID-19 vaccine as a condition of employment. There have been plenty of outbreaks in healthcare facilities that have been triggered by unvaccinated healthcare workers. And there was just something in the, it was in the Tomas Aragon's, he issued a statement yesterday regarding the necessity for healthcare facilities in the state of California to require healthcare workers to be vaccinated. And if they decline vaccination, then they have to be tested either once a week or twice a week, depending on what kind of facility they're working in. Interestingly, I come from a AFL-CIO family, but so I have been always very pro-union because my father's very pro-union. But when I was working at Kaiser and we wanted healthcare workers to take influenza vaccine, one of the barriers to that was the unions would not go along with it. We had outbreaks of an outbreak of a viral infection in the hospital, and I wanted people to, if they had symptoms, healthcare workers, if they had symptoms of this viral infection, that they needed to stay home for a certain period of time before they could return to work. This was not COVID. This was pre-COVID, because it was highly, highly infectious. And the person in HR told me, oh no, we can only say we strongly encourage. We can't say we require because of the unions. Like, really. So I think that it's complicated. The union complicates it and will definitely go to bat for healthcare workers who do not want to take the vaccine. They'll grieve it, and then the union will support them. So there's that complicating thing. As far as I know, not all healthcare workers in the Kaiser system are vaccinated. But maybe that will change with this statement yesterday from the Department of Public Health for the state.
I think it certainly is a complicated question, and one that sort of needs a Swiss cheese approach, where you overlap so many different entities are requiring vaccination that you end up covering more people, perhaps. I know what you're talking about is very similar to the UC stance, which is all staff, faculty, and students need to have have both vaccinations and a COVID test, which helps to sort of start the phone app that we're all using that gives us the green sign that we can go into campus. We also have to do a daily symptom checker. But one of the things that the UC system is saying is that you cannot ask if someone is vaccinated. And so our situation, obviously, with freight and salvage is that freight and salvage, before we come into their space, is requiring that everybody have a vaccination. So there's different levels of in some sense, I told the Swiss cheese approach. Somehow we'll get it covered.
Yeah.
The specific question: does the vaccine cover morbidly obese people, or have there been more breakthroughs?
So the only data that I have seen on breakthrough infections that has stratified the infections according to risk factor is a small study that was published from Israel. And they had something like 240 patients who had breakthrough infections, and 30% of them, I hope I'm remembering this correctly, were obese. So that was their risk factor. Some of the patients had more than one risk factor. 70% had hypertension. And remember, in this population, everybody got Pfizer. So it doesn't tell us anything about the particular vaccine, which is a question that I have. Like, are people who got J&J breaking through more than people who got an mRNA vaccine? And I've not seen any data like that from the CDC on the information that they are collecting. The closest thing that I've seen to risk stratification is from that Israeli study that was published quite recently.
Okay, great. And then the allergy to the vaccine and other and side effects to the vaccine. There's a question: a young woman with endometriosis, would the vaccine have an impact on her eggs and the ability to bear children? You say no.
No.
Okay.
And I have to say something about that infertility trope. That infertility thing, that is trotted out for every vaccination. It is often trotted out for new kinds of treatments, but it's particularly vaccinations. It is an anti-vaxxer trope that is not new, and it is trotted out every time. Anytime we have a new candidate vaccine, that whole thing is like, and you know what? They keep using it because it really works. It really works to scare people.
Mm-hmm. Got it. And then the known allergies to the vaccine. There was someone that had methylation, had gotten some genetic test, knowing that there was a methylation issue, and wasn't certain around the vaccination.
Oh, so I know that people who are allergic to polyethylene glycol
Okay.
Which is common to both the Pfizer and Moderna vaccines. Those people who have enough antibody to get an immediate reaction because of either known or just discovered polyethylene glycol allergy should not take a second vaccine. There was a study that was published within the last week, probably within the last 3 days, and I have not read it in detail, but it was reporting 59 patients who had had immediate reactions to a first dose and looking at including anaphylaxis and then giving them a second dose to see what would happen. And I think the message was that they actually tolerated the second dose quite well. But I still have to read that paper in some more detail. So,
Great. Yeah, Debbie, thank you. I'm going to ask one question about long haulers, and it has to do with the loss of taste and smell, which apparently is one of the features of the Delta variant, that more people have what's called anosmia. Anosmia. And so what does it mean to long haulers? Is it a neurologic response that is causing this?
It is. And there was a study, a longitudinal study that was published also pretty recently. Everything was published pretty recently. This was in the last month or 2 months, looking at a cohort of patients who had anosmia as one of the symptoms of their acute COVID infection or their acute SARS-CoV-2 infection. And they were followed at 8 weeks, 5 months, and 12 months. Is that right? Yeah, I think that was it. So 2 months after the onset of illness, 5 months after, and 12 months after. Most people had return of their sense of smell and taste by 8 weeks. The vast majority had return of those senses. And then they continued to follow these patients. And I believe all but 2 had regained their sense of smell and taste by 1 year. And they also mentioned that people who said, I still have impaired smell, when they were objectively tested with something called sniffing sticks, and there are these other ways that you can quantitate loss of smell, they actually had normal smell. So people, they sort of made this comment in the discussion that people can overestimate their loss of taste or smell.
Okay.
So anyway, I think the prognosis is really good for that particular symptom over time.
Well, let's go into this area, which I call risk management or risk assessment. You know, you have mentioned, you know, you calibrate your behavior based on what risk you're willing to tolerate or manage. And so, as I suggested earlier when we were checking in with each other, I'm going to give you 3 questions at once that all have different variables. And then we'll talk about the ways you think about this. So the first, member question was, I want to go to a high school reunion inside in Delaware in September. Second question, throwing outside dinner party for 45 this Saturday.
Oh.
Third question is, I want to go to an indoor performance, question mark. And then fourth, can vaccinated grandparents give their 2.5-year-old grandchild COVID? So as you answer those questions, I'll pop back in, but I want to look at the questions that have been coming into the chat room.
Okay. So the person who's doing the dinner party for 45 people outdoors, if 90 or 95% of those people are vaccinated, or hopefully 100% are vaccinated. I think that's actually pretty safe. Even if somebody were asymptomatically infected with Delta, just based on, other variants, I think that the amount of virus that they would have is low, and you're outside. And even though people are not masked, I think that's a pretty low risk situation. I think going to a play or going to a concert indoors, I probably wouldn't be planning on doing that right now, unless they required, oh, by the way, I just got opera tickets, like, I don't know, 6 weeks ago, before this became an issue. So if they require that you demonstrate proof of vaccination, that everybody present is vaccinated, I guess I might do it, but I would probably still wear a mask. I might even wear an N95 mask if I really wanted to go to this concert or really wanted to see this play. I think that theoretically, fully vaccinated grandparents who might be asymptomatically infected with Delta could infect a grandchild. I think that risk is really low. And I would, still be, I think it's okay for fully vaccinated grandparents to be around their grandchildren, their unvaccinated grandchildren. And what was the first scenario? I knew I was not going to remember all of them.
No. High school reunion.
Oh, the high school reunion.
Inside in Delaware in September.
Yeah, no, I would not be going to a high school reunion inside in Delaware in September. I would not do that.
And people that are interested in going to the concert in the Greek Theater at the end of September. It's
so
outside.
The Greek Theater is outdoors. And it's so odd. I just didn't remember how uncomfortable it was to sit at the Greek Theater. Because the last concert I went there was also Yo-Yo Ma. Anyway, I think that is probably okay. I'm not sure I don't follow Alameda County on my coronavirus tracker. I think that probably that's going to be a largely vaccinated group of people going to the Greek Theater. And it is outdoors. And although you're pretty crammed together, but I think it's relatively safe. I might wear a mask for that. If I felt like I was being crammed in pretty tightly, if you could space out a little bit, or you're on the grass up above, that might be safer. But I still think that transmission outdoors is pretty low. That risk is pretty low.
Okay, it looks like I'm going to try to get in 4 more questions from the chat room. And I'm going to start with the risk or harm of getting a 3rd dose of a vaccine. Are there any studies on that?
So there really are. So as I mentioned, the data from the booster study from Pfizer hasn't been published, and the booster mixing study from the UK hasn't been published. So we don't really have information about immunologically normal people. As far as boosters in immunocompromised patients, they tolerate the 3rd dose quite well, even though they might or might not respond to it in a robust way. However, in the study that was published of solid organ transplant patients, I think this was the Johns Hopkins study, there was a heart transplant patient who developed rejection within 7 days of receiving the booster. This was mentioned in the discussion. It's unclear whether the booster had anything to do with the episode of rejection, but it's something that needs to be kept in mind, again, because the data that we have are so limited at this time. So that's kind of what we know. And if you would want to know, I am not seeking a booster, and I am not seeking boosters for my parents. And I have told my sister and all my sister-in-laws, my sister, whatever, nobody's getting boosters in this family. And nobody's immunocompromised. The closest thing would be my 95-and-a-half-year-old father, but we're not going there.
Thank you. Kids, grandkids under 12 years old. What's the thought? Seems like there's been very little development around vaccines or thoughts about how to protect the vaccinated. And so question about children under 12. And then the follow-up question was, do you believe that at some point that schools will require vaccination like they do for measles and chickenpox and et cetera?
So I would say yes to the second part of that question. The data are, there have been data submitted to the FDA from Pfizer from the kids 5 to 11. And so I know that they are asking for extension of emergency use authorization for that age group. And I believe it was yesterday or the day before, the FDA has actually requested that they test more kids in order to provide some additional reassurance about rare potential side effects. I think the one that is of most concern is the myocarditis issue, which percolated up from people who have gotten mRNA vaccines. This is mostly in adolescents, mostly in boys. They have actually done quite well. But I think that the FDA is interested to know whether there will be cases of myocarditis in younger children, which was the reason for asking for more data. So unfortunately, that is I mean, it's good that they're being careful about this because these are kids, you know, after all, but I think that it is going to delay extension of emergency use to kids down to the age of 5. And so those kids will obviously not, unless they're in a study, they're not going to be vaccinated before school starts, which is incredibly soon. But I think that fortunately in the state of California, there will be universal masking in schools. So when kids start to be vaccinated, everybody will still, all the kids will still continue to have to mask at school.
Got it.
Not distance, but mask.
Got it. And then I think one final question. How would you describe mild COVID? What's the experience of mild COVID?
So I have heard from or read on my listservs of infectious disease doctors who are sort of writing in, saying what their experience has been with Delta and mild Delta, that it can just be like a cold, runny nose, stuffy nose. There at the beginning, people were saying they were seeing more gastrointestinal symptoms, nausea, vomiting, diarrhea. I haven't seen that recently, but it can be just like a cold, which is the reason that we don't have good information about breakthroughs, since people who just have a cold probably would not seek testing.
Great.
And it's short-lived, and you know, yeah.
So Debbie, we're at 3 o'clock. Closing remarks. As you're thinking about what you might like to say last, let me just say to everybody here, we've invited Debbie back to talk with the OLLI and Berkeley community at 9 o'clock on Friday morning, September 24th. Again, as a Zoom. And again, we will invite you to send in your questions. As we're seeing with the Delta variant, life keeps changing. Our expectations, our own sort of personal calibrations need to adjust. And I need to thank Debbie for all that you have done during this period of time in just helping so many of us better understand the science and feel like we can venture forth with best practices and still not remain in deep isolation or quarantine.
Yeah.
Debbie, your final thoughts.
So I would say that outside is best. So if you want to have people over for dinner, and this is what I'm going to do, we're just going to do it outside. And fortunately, we live in a place where you can do that right through November. So I think outside is safer, and I'm moving everything that we used to do inside to our deck and our backyard. And I'm going to keep masking in indoor spaces. And but I'm still going to try and do as many things as I can and be with my vaccinated friends as much as I can, and my vaccinated children too. So.
Thank you. And thank you all for joining us today. It has really been our pleasure to have you, to have the access to your wisdom and to your practical advice around kind of meeting good science with good practice and good friends. Okay. Yeah, thank you. Goodbye, everybody.